Hello, Dr. Aben. My research focuses on how provider stigma toward people experiencing homelessness blocks their access to behavioral health and substance use treatment, and why changing that first point of interaction can improve treatment outcomes. I believe this issue matters because a person can show up ready for help, but if they're treated as a burden or as someone who isn't ready, they may never get through the door. I've seen this firsthand working in treatment admissions. One judgmental interaction can send someone right back out to the street, and that decision can be the difference between life and death. People experiencing homelessness already face huge barriers, but stigma adds a hidden barrier. Research shows this leads to lower engagement in treatment, higher dropout rates, and worse health outcomes. It also reinforces the idea that homelessness is a personal failure rather than something shaped by systems like housing availability, trauma, or mental health. My audience includes social workers and behavioral health professionals, policymakers, the people who will be in these positions making decisions. Some already know stigma exists, but many underestimate how their tone, assumptions, or documentation directly impact access to care. I want to show that stigma isn't always intentional. It can come from burnout, it can come from fear or policies, but the harm is the same. I'm using evidence from both frameworks and practical studies like the link and felon stigma model that explains how labeling and inequality show up in treatment systems. I'm also relying on research that measures outcomes tied to provider attitudes because this isn't just about feelings, it's about measurable harm. And I recognize my own bias here. My experience gives me insight, but it also means I have to work hard to stay balanced and avoid blaming the very people doing the work. My solution focuses on provider training and support, building empathy, reducing burnout, and holding organizations accountable for stigma related barriers. We don't need new buildings or huge budgets to start creating access, just a change in how we treat the people who walk through our doors. If we keep ignoring this, we'll keep cycling people through crisis care. But if we address stigma at the point of access, we can give people a real opportunity to stabilize, a real opportunity to enter recovery, and a real opportunity to rebuild their lives. And that strengthens entire communities.